I'm seeing Melinda. She's a 27-year-old female with a chief complaint of migraine headaches, although she does not have a headache at this time. She states she has had headaches since the age of 12. They were better, now they are worse again. She has not had them this severe since she was a teenager. The headaches started to get worse after the birth of her second child. They're now more frequent, more severe. She reports she often vomits with her headaches and the pain is throbbing. They occur about every 2 to 3 weeks and last about 2 to 4 days. She has been to the ER 3 times in the last 6 months. Reports they did give her an injection for the pain. Subjectively, social history reveals she's married with 2 young children, ages 18 months and 5 years. She works part-time as a cashier. Subjective review of systems include that the headache pain. She reports the headache pain is usually on the right side in the temporal and parietal regions, although occasionally the pain will be on the left. She denies dizziness, weakness, double vision, blurry vision. She denies nausea, vomiting, diarrhea or constipation or heartburn. She denies fatigue except for during a headache. She has no recent weight loss or weight gain. She denies anxiety or depression. Objectively, her vital signs are stable. Her temperature is 98.2, pulse 88, respiration is 20, BP 132/86. On exam, she is Perla. TMs are unremarkable. Nares benign, pharynx benign, no lymphadenopathy, no thyromegaly. Her lungs are clear to auscultation. Heart rate has regular rate and rhythm without murmur, rub, or gallop. She has no peripheral edema. Neurological exam is unremarkable. Differential diagnoses include number 1, a combined tension migraine headache per Ferry 2015, page 1316. This is suspicious for this type of headache in combination with the fact that she has migraines because she is normal between episodes. They are long-lasting, throbbing, and she has vomiting during the episodes. This is less likely due to the fact that she states they can last up to 4 days, although the fact that they are combined tension and migraine headaches may indicate that the tension headache picks up when the migraine resolves. This would also account for the fact that the headaches are typically unilateral, as with migraines, but sometimes bilateral, as with tension headaches. Diagnostic studies are not typically indicated for this patient due to a normal neurological exam and denial of dizziness or weakness. This is a likely diagnosis. Number 2, tension headache is somewhat likely due to the patient's report of the headache being bilateral at times and the fact that they became worse after the birth of her second child. Tension headaches are often associated with stress, sleep deprivation, and psychological factors. According to Ferry 2015, they can last up to 7 days. And patient reports that her headaches sometimes last up to 4 days. This is less likely due to no report of a band-like sensation on her head, the fact that she has throbbing and vomiting, which typically do not occur with tension headaches. Diagnostic testing would include a CT or MRI to exclude intracranial pathology. If the patient were over 50, a SED rate should be ordered to rule out temporal arteritis, although she is not, so this would not be applicable in her particular case. Tension headaches are somewhat likely. Number 3, differential diagnosis are cluster headaches due to the fact that the headaches occur in predictable clusters. They affect the temporal area. Since cluster headaches may occur in groups of up to 8 per day, the patient should be questioned further as to whether the headaches are truly lasting for up to 4 days or whether she is having short headaches throughout the day at intervals. As I said, they can last up to 8 or occur up to 8 headaches per day. This is less likely due to the length of time that they occur, as they typically do not last past 180 minutes per Ferry 2015. However, it is possible she is having cluster headaches as well as migraines. These are less likely due to the denial of sweating or lacrimation, or no presence of sweating or lacrimation during the attack. No diagnostic testing is needed as long as neurological exam is normal. However, an MRA of the brain may be warranted.